Thank you everyone for joining our Debbie's Dream Foundation Curing Stomach Cancer webinar series. Today's webinar on targeted treatments and immunotherapy is the second in a series of 12 monthly webinars. I am Margaret and I will be moderating today's webinar. I am the Programs Director for Debbie's Dream Foundation Curing Stomach Cancer. I'm a licensed marriage and family therapist and recently completed my doctorate. My clinical and research background is focused on working collaboratively with doctors, patients, their families, and members of a healthcare team. We would like to thank our title sponsor, Boston Biomedical, and our platinum sponsor, Lilly Oncology, providing the funding to make this webinar possible. You will be able to ask questions during this presentation. You can do this by typing your question into the white text box that appears on your screen. At the conclusion of the presentation, we will address questions as time allows. In addition, the recording of this webinar will be accessible on our website in approximately 1 week. First, I will share with you information about our president and founder, and as well as Debbie's Dream Foundation Curing Stomach Cancer. Then we will hear a presentation by Dr. Daniel Catenacci of University of Chicago, and then we will conclude with a question and answer session. Pictured here is our president and founder of Debbie's Dream Foundation Curing Stomach Cancer, Debbie Zelman. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. A practicing attorney and mother of 3, she had no risk factors for stomach cancer, and her symptoms were very vague. At the time, she was told that her chance of being alive in 5 years was only 4%. She has endured harsh chemo regimens and targeted treatments and has experienced several recurrences over 8 years, although her 9-year anniversary will be coming up next month. And she is still a patient to this day. Debbie founded DDF in April of 2009. As an organization, we are a member of several advocacy coalitions, including the Deadliest Cancer Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. Debbie also serves as a patient advocate on numerous committees and task forces. Some of you may be familiar with the facts and statistics about stomach cancer, and they are continually being updated. In 2017, it's estimated that more than 28,000 Americans will be diagnosed with stomach cancer, and more than 11,000 will die. 80% of all patients are diagnosed at stage 4, when the 5-year survival rate is only 5%, and the incidence rates in younger populations has increased, while the expected frequency has been on the decline. Yet many know very little about this deadly disease. And so Debbie's Dream Foundation is dedicated to raising awareness about stomach cancer, advancing funding for research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more about our organization by visiting our website at www.debbiesdream.org. In the few short years that DDF has been in existence, we've achieved many great milestones. We have 27 chapters across the United States, Canada, and Germany, and events are ongoing around the country. Our patient resource education program helps patients, their families, and caregivers around the world by matching them with survivors and caregivers using disease-specific criteria, including staging, biomarkers, and location. We host educational webinars like the one you're listening to today, as well as symposia year-round, and our website contains in-depth information about stomach cancer that can be translated into more than 60 languages. We have also provided $650,000 in research grants and advocated during our Stomach Cancer Capitol Hill Advocacy Day to add stomach cancer to the Department of Defense's peer-reviewed cancer research program, resulting in $5.8 million being awarded to stomach cancer researchers in fiscal year 2015. And here's a snapshot of our website's homepage, and you can see that there's numerous links to resources and information, including our online stomach cancer support community. You can see some of the many events we have on the horizon, including our 7th annual Stomach Cancer Education Symposium being held in Hollywood, Florida on April 29th. The symposium will be live webcast around the world as well as translated into Spanish. So if you cannot join us in person, please register for the online webcast and join us. On the evening of April 29th, we'll be hosting the 8th Annual Dreammakers Gala, a night dedicated to celebrating the year and accomplishments of Debbie's Dream Foundation. There are races and outings planned throughout the year nationwide. For more information about these and other events, please go to our website and click on Events. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday from 8 a.m. to 5 p.m. Eastern Time. Also on this slide are important phone numbers and email addresses you can use to contact our office and staff. We will start the presentation, made possible in part by our title sponsor, Boston Biomedical. The topic of today's presentation is targeted treatments and immunotherapy, and our presenter is Dr. Daniel Catenacci of the University of Chicago. Dr. Catenacci is an assistant professor of medicine and the associate director of the GI oncology program at the University of Chicago. His research is focused on normal and cancer cell signaling with the ultimate goal of developing new inhibitory drugs for the treatment of gastroesophageal cancer, among many other professional goals and accolades. We are very proud to have Dr. Catenacci as a member of the DDF Medical Advisory Board. So at this time, I would like to turn the webinar over to you, Dr. Catenacci.
Thank you very much. Okay, so today we're going to talk about targeted treatments and immunotherapy for gastric and gastroesophageal cancer. You can hear me well, I hope. So next slide, please. So just a few background slides to set the stage and understanding when we do speak about targeted therapies and immunotherapy. You heard earlier with the stomach cancer at the bottom there being gastric or non-cardia adenocarcinoma. There are some other subtypes that are further up the tube, the EGJ or esophagogastric junction adenocarcinoma as indicated there, and then the most proximal esophagus squamous cell carcinoma. So today, as you'll see as we go forward, the bottom two, esophagogastric junction adenocarcinoma and gastric adenocarcinoma, are often lumped into one and referred to as gastroesophageal adenocarcinoma. And for the most part, most of the studies and trials and even treatment approaches sort of treat these as one entity. So next slide. And as you heard earlier on the left, gastric cancer in the United States, these are the estimated new cases per year and deaths per year from the disease. And on the right, esophageal cancer, of which most is esophagogastric junction adenocarcinoma. And that GE junction is increasing in incidence in Western countries, including the United States, by 400%. And so, next slide, taken together worldwide, in 2012, the last census, gastroesophageal cancer accounts for more than 1 million deaths per year, which is the third in cancer incidence and second in cancer death. Next slide. And this is shown here broken down by gender and by the two subtypes, stomach and esophagus. On the left, new cases per year, and on the right, estimated deaths as opposed and in contrast to other primary tumor types. And then next slide, taken together again, we see that the incidence for esophagogastric cancer is third, and next slide, the second highest in estimated death. So it is a serious global problem of high incidence and poor prognosis. So next slide. So when we talk about staging, which is important, and on the bottom left there, we see that if one is lucky to be found at an early stage, stage 1, surgery alone is considered sufficient, and 5-year survival rates are good, and patients tend to not have recurrence. On the other hand, locally advanced disease, or stage 2 and 3, surgery alone has a 5-year survival rate of approximately 25%. So over the last decades, a number of strategies were tested to see if, on the left, chemotherapy in various strategies, either before or after, or both before and after, or on the right, chemoradiotherapy before or after, would help to enhance the cure rate, which we call a 5-year survival rate. And so as you can see here, the various strategies are very similar when you look at hazard ratio. This is important for us. We use that number to determine the benefit over the. And so when the hazard ratio is less than 1, that is a good thing. That shows that the treatment intervention is better. So as you can see, these various strategies comparing to each other across trials are very similar. And so there is some controversy in terms of which is the best one, and different physicians and centers approach this in different ways. But next, moving forward, next slide, we see that overall, no matter what is done, the absolute survival at 5 years is increased about 10 to 15% when doing one of these strategies. And so the 5-year overall survival is approximately 40%. So there is consensus then that something other than surgery alone should be done for locally advanced disease, and that we need to do better, because no matter what we do, 5-year overall survivals can be improved on. And so in this setting, more often than not, patients will have their cancer come back. The other important point is that many or most patients present at newly diagnosed when they're already stage 4, when it is already spread and not removable surgically. So we're either talking about stage 4 disease at the onset or stage 4 disease after undergoing this therapy that's on this slide and having it come back. So next slide. So another important thing in the stage 4 setting is when a physician, you meet a physician and they tell you about what the prognosis is and the median overall survival. So what does that mean? So looking at a basic standard treatment here, this is what we call a survival curve, where on the left, on the bottom axis, which is going from 0 to 18 months, at time 0, when a patient is diagnosed, on the up and down axis, which we call the y-axis, 100% of patients are still alive at the time they're diagnosed. As time goes on, patients start to die from their cancer. And so in order to represent this survival curve, we would say, next slide, the median survival time, next slide, in this example with this treatment is 3 months. And so what that means is 50% of patients are still alive and 50% of patients are not alive anymore at that time point. So with this example, standard treatment here is 3 months. Now when we test a new therapy and we find, next slide, that the median survival is improved to 9 months, this is what this is representing. And so the important point to take home here when a physician says that to you is that that's not what's going to necessarily happen to you. That is representing what is expected over time from a population. And you can see that 50% of patients are still alive at that time point. And as you go on in time to 18 months, for example, 1 year and a half, in this new example from the new treatment, still 20% of patients are still alive. So that's an important take-home message, that just because you're being quoted a certain time point, there is a wide range around. I mean, we heard earlier that Debbie Zelman is alive 9 years later after the diagnosis of stage 4 gastric cancer. Now that is not usual, because as you go on over the timeline, more patients are succumbing to their cancer, but it is possible, and that's an important point to know. So next slide. Now, talking about therapies, standard chemotherapy, you can see that there are a number of different treatment options when a patient is diagnosed with stage 4 cancer. These are indicated on the left by acronyms, and those acronyms are defined below in the box that is red. And the green bars refer to doublet regimens, 2 chemotherapy regimens, and the orange bars refer to triplet regimens. This is compared to best supportive care at the very top. So without doing any therapy historically, we see here that median overall survival, remember the previous slide what that means, is approximately 3 months. With these various different treatment regimens, all from various studies referenced here, the median survival can be improved to a range of around 9 to 11 months. And so, in short, any of these therapies could be considered possible. Next slide. So this starts talking about lines of therapy, something that one needs to understand when they're diagnosed and the physician is speaking to them. So first-line therapy, although there are a number of different options here, it is becoming a national trend and a global trend to go to a regimen called FOLFOX. That is a 2-drug regimen that, as you can see on the last bar, has outcomes similar to others and is also very well tolerated compared to, say, some of these triple-drug regimens. So that is a standard go-to option. And then one must understand also that even in the best-case scenario, that when a treatment is working eventually we are expecting that some areas of the cancer will learn how to grow, and that would determine a time when we need to change to a different chemotherapy or second-line therapy to try and treat the cancer in a different fashion. So there are some standard second-line and then third-line chemotherapy regimens that could be used, frankly, in either order. So that would be standard approach and the standard expected median overall survival with standard cytotoxic chemotherapy. Next slide. So next we talk about targeted therapy. So what is that and what is that all about? So the previous webinar was talking about how to identify genetic events, I understand. And so we understand in this tumor type, there are many, and that what this slide is representing, that on the far left, that there are very few genetic events that are common in this disease. And as you go across from left to right, that there are numerous genetic events that are uncommon. So the lower the bar, the less frequent it occurs. And so this pie chart sort of represents that heterogeneity of genetic mutations when we looked at 100 patients. This has been well described and understood. But this is important, next slide, because we understand that these genetic events can lead to activation of that gene's product, which we call a protein, and leads to excessive cell growth signaling. So this is a very complicated slide, but what it's representing is in the top, which is light blue, outside of a cell, and then there's a line, I wish I could point, but there is a line separating the light blue on top and the orange on the bottom. That is the cell membrane, and then inside is the light orange, which is inside the cell. And so what this is representing in even normal cells is that there's a lot of cell circuitry that's going on and appropriately turning on and off this cell cascade of signaling to say a cell should grow or it should stop growing, and that is all regulated very tightly. When a gene is mutated, like for example, next slide, HER2 or amplified in this disease, that can lead to excessive signaling from that particular protein that is continually telling the cell to grow and grow and spread. And that mutation, therefore, is what the definition of cancer is. And another, next slide, protein at the receptor called VEGF-R, or vascular endothelial growth factor receptor, is also important in various cancers, including this one, where it leads to tell the surrounding blood vessels to grow towards the cancer so it can get nutrients. So the cancer is having blood vessels form towards it through this particular mechanism. So the reason why these circles are in green is because these two of all the potential things written on the slide have been tested and proven to work effectively in this cancer. Next slide, and we'll talk about that on the next slide. So let's talk about HER2 first. So HER2 is a gene that we all have, but in this type of cancer, it's abnormally activated or amplified in about 10 to 15% of patients. And as you see on the slide, there are a number of different ways to inhibit this signaling with so-called targeted therapies. So next slide, you can go ahead, 4. You can see that each one of these circles represents a different drug which inhibits that receptor for HER2 in various fashions, different ways, outside the cell or inside the cell, etc. We're going to talk mostly about the first circle, trastuzumab or Herceptin, because that is the only one that has been tested and proven to improve overall survival in this cancer. Next slide. So superimposing HER2 studies on top of the previous bar chart of overall outcomes with just standard therapy, the purple lines refer to a study that was called the TOGA study that was published in 2010, and that study tested and selected for HER2 positive patients. Next slide. So what we see here, and next slide, that we've subdivided into 3 bars. The top purple bar was the actual study that was done. And next slide. That was a consequence of screening about 3,800 patients and testing them to see if they were HER2 positive. Only, remember, around 15% of patients are HER2 positive. So that's how many patients were needed to be tested in order to find the numbers needed to run the study, which was a planned about 600 patient study. So the top purple bar represents that study of 600 patients, where the dark purple was the placebo group that got chemotherapy alone. The extended purple bar with the plus trastuzumab or plus T was the treatment arm and their benefits from getting that trastuzumab, so their median overall survival improved. The second bar that we're looking at that says IHC 3 plus or IHC 2 plus FISH positive is a subset analysis of that larger trial of just those patients that have actually what we currently call HER2 positive, meaning they have to have immunohistochemistry expression, IHC, of at least 2 plus. And if you are 2 plus, it also has to be a FISH positive, which is another form of testing for the gene copy number. So in that subset analysis, you can see that those true positive patients have a median survival approaching 16 months compared to the placebo group, which was less than 12 months. And then finally, the lowest bar, which is really the really high expressing patients, IHC 3 plus and FISH positive, their median overall survival are approaching 18 months. And so this was revolutionary and has become a standard of care of targeting this type of cancer, patients with HER2 positive disease, because median overall survival was improved almost 6 months in the really high expressors and about 4 months in the currently positive, what we clinically call positive expressors. So next slide. Unfortunately, follow-up studies, which are the second, third, and fourth row of this table, which are circled in red because they were negative, unfortunately were negative in the first line, looking at a different type of drug, which is the LOGIC study called Lapatinib, another anti-HER2 drug that is an oral medicine. And that study, again, was comparing to chemotherapy, but was negative. And then 2 second-line studies, so after failing first-line anti-HER2-based therapy, 2 second-line studies, one with Lapatinib, called the TITAN study, and one with TDM1, which is trastuzumab conjugated with the cytotoxic therapy, and that also was recently reported as negative. So next slide. It's not, so different targeted therapies have different properties, and so trastuzumab Herceptin is the only one to date that has been tested and confirmed to improve survival and a standard of care in only the first-line setting. The bottom left abstract was presented last year at our annual meeting in June, and was a study looking at patients who had already been treated with first-line chemotherapy with trastuzumab that were HER2 positive, and in the second line was giving standard chemotherapy with a drug called paclitaxel with trastuzumab, the T, or trastuzumab with a second targeted therapy that was also an inhibitor of HER2 and HER3 receptors. It was a relatively small study, but the point is, in the next slide, that we want to point out 2 things that are important that we are beginning to understand, the most important being the second one. The first one, next slide, is that patients that were tested on this study had their original samples retested centrally. And it turned out that about 38% of them were considered HER2 negative right from the start. And so that is demonstrated on the graph that just showed up. I apologize that it's a little blurry. But what this graph is showing is the FISH score, which is what the pathologist will use to determine whether a patient is HER2 positive. So on the x-axis, the bottom axis, is the FISH ratio when a patient is diagnosed. And on the y-axis, the one going up and down, is the FISH ratio when the patient is having a repeat biopsy just before getting second-line therapy. So next slide, what the first point is that there was a subset of patients that were tested centrally on this study, and they were negative both at diagnosis on the x-axis and negative on the y-axis just before starting second-line therapy. Negative being less than a ratio of 2. So there is some subjectivity to this, and when it's repeated from a standardized point of view, there are a subset of patients that may not even be HER2 positive. But more importantly, the second component, next slide, is that patients that were diagnosed as being HER2 positive at diagnosis with ratios above 2, and this circle here between 2 and 10, clearly positive, at the time that they progressed on first-line therapy and a repeat biopsy was done, these patients in that second circle were now less than a ratio of 2, meaning they were converted to being HER2 negative. And we're starting to understand that this evolution of genetic events over time is quite important. And so one might expect that a HER2 negative patient would not respond to a HER2 targeted therapy. And so this is an important thing to understand. Over time, things can change. Next slide. So the other big receptor and targeted therapy that is approved in this disease is called antiangiogenesis, or anti-blood vessel formation that we talked about. And what this slide is showing, a number of different circles, which we call ligands, that can bind to receptors and stimulate them to create blood vessels. And so on the far right, there is an antibody called bevacizumab, or Avastin, which binds just to that one ligand called VEGF-A, and inhibits it, neutralizes it, and prevents it from stimulating those cells to form blood vessels. Similarly, there are other drugs like that, aflibercept in the middle, top middle, that binds to all of those ligands. And then finally, there is a drug called ramucirumab that binds to the receptor VEGF-R2 and inhibits it that way by inhibiting the receptor directly. Finally, on the bottom left, there are some drugs that get inside the cell where the orange part is and bind intracellularly and inhibit the receptors in that manner. Lapatinib is one of them that we'll talk about. Next slide. So these drugs are important because ramucirumab, the drug that binds directly to the VEGF-R2 receptor, was tested in the second-line setting after failing first-line therapy. First-line therapy stopped working. And the first study, REGARD, in the top row, was testing ramucirumab versus placebo. This was studied that was done almost a decade ago now, started, and showed benefit over the placebo in the second-line setting. More importantly, I think, is the RAINBOW study, the second line, which was testing chemotherapy with or without this study drug ramucirumab. And you can see that the overall survival was improved by the addition of ramucirumab from 7.4 to 9.6 months. So therefore, this has become a standard of care option to use, is the addition of ramucirumab either alone for the REGARD study or in combination with paclitaxel for the RAINBOW study. The bottom row refers to a study that was recently presented from China, looking at, in the third-line setting, a drug, Lapatinib, versus placebo. That is the drug that goes inside the cell and inhibits receptor, and showed similar survival benefit. This is not approved here in the United States, but there are studies looking at this same question in Western populations. Next slide. There are some back one slide, please. Sorry. There is one study called the AVAGAS study that was looking at bevacizumab, or Avastin, and it was done in the first-line setting, and it was unfortunately negative when it was added to chemotherapy. Chemotherapy plus bevacizumab was not any better than chemotherapy alone in terms of median overall survival. There is an ongoing study called RAINFALL, which is looking at chemotherapy with or without ramucirumab in the first-line setting, which is fully accrued, and we are awaiting the final report, which we are expecting in the next year or two. Next slide. So there are a number of studies that unfortunately have used targeted therapies and have been negative. So we're going to focus on the largest studies, the phase 3 studies, next slide, which looked at the receptor EGFR, next slide, MET, and the ligands, inhibiting the ligands, next slide, HGF, hepatocyte growth factor receptor, next slide, and looking at a protein downstream, we say, called MTOR, which is basically looking at this and saying we can inhibit the signaling transduction anywhere along the path. So we're going to talk briefly about these three large studies. Next slide. So as opposed to the HER2 story, where patients with HER2 amplification were sought after, and those were the only ones that were enrolled and treated, in the anti-EGFR trials, of which the big three are listed here, this was for all patients. They were not selected in any way. They weren't selected for any genetic event. And you can see that there are two first-line studies and one second-line or higher study. The top two first-line studies, EXPAND and REAL3, they looked at chemotherapy with or without the anti-EGFR antibody cetuximab in the case of EXPAND, or panitumumab in the case of REAL3. And these were both negative studies. The final bar row, which was looking at a drug called Lapatinib, which again is a small molecule of oral medicine that gets into the cell and inhibits the receptor from the inside, it was looked at in the second and later line setting, and it was negative, unfortunately, compared to placebo. So EGFR therapy is not indicated currently in this cancer for these reasons, because they were all negative studies. However, next slide, we do know that EGFR is gene amplified in about 5% or so of cases in this disease. So it's not common, but it does happen. And there has been some correlative studies from the bottom row study, COG, called TransCOG, Translational Correlative Studies, looking at just that subset. And that subset of patients, which amounted to only around 20 of that 450 total patient set. But in those patients, the patients who received Lapatinib did much better than those who were on placebo. And the hazard ratio, what I put an exclamation mark, is 0.19 in that subset analysis. Now, this is not enough to go on because it is a small sample set, and that's subject to random variation and does not lead to approval. And it highlights some of the difficulties in studying these very small subsets of disease, because you need so many patients in order to find them. And looking back at the HER2 example, almost 4,000 patients needed to be screened just to find enough patients to put on the study, and that was at a 15 to 20% rate of HER2 amplification. In this setting of 5%, more than 10,000 patients would need to be screened in order to find those few that were EGFR amplified, and that has been a big challenge in studying genetic events in this disease, because there are many of them at very low frequencies, and EGFR is one example. Next slide. This is highlighted from our own patient data set, where over the past 2 years, we looked at about 150 patients with metastatic disease in various lines of therapy when we first met them, and we found, again, exactly what we would have expected. Around 5% were EGFR amplified, 8 of them. And of those, we were able to get EGFR therapies on studies for 6 of them. And you can see their response rates were very high. So that chart on the left is showing at 0, meaning that nothing would change, or if it had gone up or grown, it would have increased in size, and the bar would be going above 0, of which none of these patients had. And as you look, minus 25, minus 50, minus 75, that is the amount of shrinkage that was seen in each of the patients. So next slide. One of the remarkable ones is a patient who was in third-line therapy and was treated with monotherapy cetuximab, an anti-EGFR antibody, and has had a dramatic response, and it remains on therapy more than a year later in the third-line setting. So it is promising, but it's very difficult to prove with statistical significance because it's so rare and uncommon. Next slide. Similarly, another receptor, MET, which is another oncogene, looked at in 2 large phase 3 studies. You can see them listed here, RiloMET1 and MET gastric. And these were looking at 2 different chemotherapy backbones, FOLFOX and epirubicin cisplatin 5-FU, with or without the targeted therapy. Both, unfortunately, were negative. Now, these patients were selected in both studies for what we call MET expressing, MET overexpressing, which amounted to about 80% of patients in the one study, RiloMET1. So this study was, both studies were negative, and MET therapies are not indicated in this cancer. However, similar to HER2 amplification and EGFR amplification, MET is gene amplified in about 5% of cases. Next slide. And that is also important and leads to potential for inhibiting in those patients that actually have genetic driving function of that gene. Next slide. And there have been some studies that have looked at this. One of them we reported a few years ago now, which was looking at a drug called AMG 337, which was a drug that gets into the cell and inhibits the receptor from the inside. And you can see in this particular patient, a 64-year-old with metastatic gastroesophageal junction cancer who had MET amplification, and you see the PET scan on the left, all those black dots are cancer spots that are active, and the PET scan on the right, after 5 weeks of therapy, completely resolved. And this patient, you can see on the bottom left curve, their percent of change in their tumor burden eventually getting down to minus 100%, meaning complete response, or CR. And this patient lasted for more than a year, and that's the last I've heard, and this has been some years ago. So this patient derived significant benefit. And this, again, was in the second-line setting after failing FOLFOX chemotherapy very quickly after only 9 weeks. Next slide. This patient is not the only patient that has been reported to have this. This was the full data set of that same report, of where we were able to identify 13 patients, of which 8 patients had a response rate, which is defined as minus 30% shrinkage rate or more. And so this again highlights that over several years at several sites looking for these rare patients, we were only able to find 13. And so, as promising as this is, it's very challenging to prove with the thresholds that are required in order to get a drug approved for therapy. Next slide. Finally, another targeted therapy approach looking at a protein called MTOR in 2 large studies, both in the second-line setting, with a drug called everolimus in both situations, either alone compared to placebo or alone or in combination with chemotherapy, were both unfortunately negative. We should note that, again, these targeted therapies were given in unselected patients, so targeted therapies in untargeted population. Next slide. So switching gears here for the remainder of the talk to immunotherapy. Immunotherapy is an important buzzword lately, and so we're going to focus on what that is and what are the data in terms of using these inhibitors in this cancer. So this slide represents some background that one should understand when we're talking about immunotherapy, and that is, how does our immune system work in general to suppress cancer? So starting with the tumor on the left, that is red, tumor cells grow and they divide and they die at a certain rate. When they die and rupture, all those little red dots, which we call antigens or proteins, can get into the lymph system and travel through the lymph system to our lymph nodes. In those lymph nodes reside antigen-presenting cells, or APCs, indicated here in purple. Those antigen-presenting cells suck up those antigens and present them on the receptor, which is blown up on the top right. That APC cell is expressing the antigen, which can be recognized by a very unique T cell. T cells are a component of our immune system that recognize and kill various things, including bacteria and and in this case, tumor cells. So when a given T cell is stimulated by the antigen-presenting cell that is presenting that very unique antigen unique to the tumor, that T cell expands and proliferates, and we get many of them. Then those cells return back through the bloodstream, and when they come in contact with tumor cells that express that antigen, they kill them. That's what we want to happen. This cycle of events is what our immune system normally should be doing. Next slide. So the problem is that tumor cells, like our own normal cells, have learned how to evade our immune system from being attacked. So if we didn't have that, we would have autoimmunity. Our immune cells would attack our normal cells. So one of the many ways that the cells can do this, including tumor cells, is to express a protein called PD-L1, and that is indicated in the left on the top blue cell expressing that receptor. that PD-L1 receptor will bind to PD-1 receptor on a T cell. When that happens, that will turn off the T cell, and the T cell will not attack the cell that is expressing PD-L1, in this case, tumor cell. So what is an immunotherapy? What is an immunotherapy checkpoint inhibitor? These are called checkpoints to keep the immune system in check. So we want to inhibit that in the setting of a tumor cell, using that or hijacking that pathway to evade our immune system. So there are a number of companies with a number of immune checkpoint inhibitors that bind to either PD-L1, as indicated with the green loop, or bind directly to PD-1 on the T cell, that green circle. When that is interrupted, that interaction, now the T cell can re-recognize that tumor cell as being abnormal and will kill it. So, next slide. We know that these agents have been approved in other cancers, lung cancer, head and neck cancer, bladder cancer, melanoma, etc. But what about this cancer? Where are we at now? So this was the first report and the first publication of any immunotherapy in this disease, which we were involved in. And it was called Keynote-12, which was a large study that included many tumor types, of which one cohort was gastric cancer. And it was for only patients expressing PD-L1 in their tumor. And that was determined by immunohistochemistry. So next slide. This was the result of patients who, most patients were in third-line therapy or higher. And it showed a disease control rate that was very high and a response rate that was centrally reviewed of around 22%. So this was very promising. It was in a relatively small sample set of around 60 patients, 30 from Western countries and 30 from Asia. But it was very remarkable because we don't tend to see this at this setting after failing previous standard chemotherapies. Next slide. And this is what we call a spider plot, or in Italians would call a spaghetti plot. And this is showing in orange patients who had shrinkage of their cancer and the duration in weeks, and patients who had growth in their cancer, and shown in green. And so you can see here that there was around a 20% response rate. But the most notable thing is that when patients responded, they respond for a long time. And so this was very important for us to recognize. Next slide. Now the next follow-up study, which is Keynote-59, next slide, is going to be presented this year in June with a much larger sample set of almost 260 patients with both PD-L1 positive and PD-L1 negative status, and these will be looked to eagerly to kind of make a more definitive assessment and see whether these drugs can be approved in this setting. Next slide. What we do know is that microsatellite unstable high patients, or MSI high, which is a status of genetic changes that is very unique to given tumors, but it's rare in the stage 4 setting in all diseases, including the stomach cancer. Less than 5% will have this, but when you have it, the response rate is really high. In the one published study to date was around 75%. And that is higher than standard chemotherapy in the first-line setting, let alone these patients who have been through many lines of therapy. So this is very remarkable, and we look to whether or not this will be an approved indication going forward as well. Next slide. There are other drugs. So the previous was pembrolizumab or Keytruda. This study is with nivolumab or Opdivo, which is called the Checkmate 32 study for this type of cancer, also recently reported. Next slide. Now this study looked at not only PD-L1 positive but also PD-L1 negative patients together. So the response rate is lower, as one might expect, because PD-L1 positivity tends to enrich for more patients that are more likely to derive benefit. So the response rate in this relatively small study was around 15% of patients in all comers. Next slide. Again, the spaghetti plot showing the patients that do respond, which is the ones that start at 0 and drop down, get smaller in light blue here. They tend to respond for a long time, especially in this setting of already being through standard treatment. This is a good time to sort of take a side thing to talk about what we call pseudo-progression. and that is talking on the right paragraph there, showing that few patients had initial progression or growth of their cancer while getting the treatment, and then after a period of time started to shrink. You can see basically just one patient that goes up initially and then drops down significantly and actually goes into CR by week 36, and that's the black line that going up and then back down. So this pseudo-progression concept is something that we all sort of look at to ensure that we don't stop the therapy too early and let it give a chance to work. The other counterpoint, though, is to note that this happens very, very rarely, at least in this cancer with this type of therapy. It did not get reported in the previous keynote study, and in this study you can see that it was just one of all of those patients. So can it happen? Yes. Is it common? No. And so, you know, we don't want to keep patients on therapies that aren't working, but it is worth it to just consider that if otherwise you feel well and patients feeling well, to give it a little bit more of a chance before stopping too early. Next slide. So most recently, this is the largest data set now to date looking at gastric cancer with immunotherapy, and that was reported a few months ago at our annual GI Cancer Symposium in San Francisco, which was looking in a Japanese population at nivolumab or Opdivo in later lines of treatment, either second or later lines of therapy, compared to placebo. And you can see there that this is looking at progression-free survival, or the time point at which it was deemed that the therapy was no longer working or growing. And you can see that the blue line is the treatment arm with nivolumab, showing slight benefit compared to the placebo, where the median progression-free survival time was 1.6 months versus 1.45 months. Next slide. However, this translates to a survival benefit of a median of 5.3 months over a median of 4.1 months. The most important thing that I would take from this is the green circle, which has moved a little bit with the formatting, but looking at the percent of patients alive at 12 months after starting this trial. And the percent of patients alive with placebo was 11%, and the percent of patients alive with nivolumab was 26.6%. So there's about a 15% benefit of getting this therapy in all comers. We are anticipating or looking very closely at whether or not we can better select patients with various biomarkers like PD-L1, because this study included both PD-L1 positive and PD-L1 negative patients and was not reported. So it would be interesting, and we'll be looking at this in trials going forward, what the differences are, or if there are any, between PD-L1 positive patients and PD-L1 negative patients. Next slide. So in summary, we've talked about median overall survival and what that means with just general standard chemotherapy for HER2 negative patients is on the order of 9 to 12 months. With HER2 positive patients, the addition of trastuzumab in first-line therapy has a median survival of 14 to 16 months with that targeted therapy for that targeted population. Next slide. We talked about standard chemotherapy, which includes 5-FU, platinum, irinotecan, and taxane, and also the standard targeted therapy that can be used for all comers in second-line therapy and their benefits. Next slide. And we've talked about first-line therapy, where there are various 2- and 3-drug regimens. 2-drug regimens are preferred because they have similar outcomes and are less toxic. One standard go-to option has emerged, which is FOLFOX, 5-FU, with oxaliplatin. We know that first-line therapy, just standard chemotherapy, can improve quality of life and survival, has a response rate generally of around 40% and a good disease control rate of around 70%, and that we can treat and prevent symptoms and improve survival time. Next slide. Second-line therapy, we also talked about standard agents, either 1 or 2 drug regimens, 2 preferred. We know that ramucirumab is standard here, and that response rates are around 30%, and disease control rate at about 50%. Next slide. We know that third-line chemotherapy, although it doesn't have as large a data set in phase 3 studies, there is evidence, and it is routinely used and has a response rate of approximately 15% and a decent control rate at that time. Next slide. We talked about targeted therapies, how they work, and the ones that are approved in this disease, namely trastuzumab for HER2 amplified patients and ramucirumab for all patients in the second-line setting. We also note that one-size-fits-all approach for negative for patients that don't have a given genetic event have been negative trials and not impressive. Next slide. We talked about immunotherapy and how checkpoint inhibitors work. We talked about biomarkers that might help us select for those who are most likely to respond and exclude patients who are unlikely to respond. Next slide. We talked about some other high-yield genetic events that can be targeted and have some data around that, and that other studies are being done to try and increase our understanding of this. Next slide. And finally, my last comment will be that there are a number of studies ongoing now trying to combine a number of these approaches in earlier lines of therapy. First line, for example, combining immunotherapy with chemotherapy, combining different types of immunotherapy checkpoint inhibitors, combining targeted therapies with these immunotherapies and chemotherapy, and all of these various combinations, it is likely, or at least possible, that we can improve outcomes by adding these things together, because they all work sort of in different fashions and they can be synergistic. So I'll stop there, and thank you for your attention.
Dr. Catenacci, I want to thank you so much for that informative presentation. I know this is a very comprehensive subject, but I really appreciate you taking the time to go through and explain each of the different mechanisms and how everything works. I do want to go ahead and start reading some of the questions that we received during the presentations, and you still have time if you'd like to ask a question. Feel free to continue typing it in as we go through the questions and answers. First up, the question is, in second and third line studies, are prior lines of therapies examined to determine if specific successions of therapies were effective or have different efficacy rates?
That is an excellent question, and it's really challenging to do that, especially in this cancer type, that as you saw in the previous slide, that there are a number of options for first-line therapy. Although I mentioned FOLFOX is emerging as a go-to first-line therapy, it certainly isn't the only one used. And so when study eligibility indicates you have to have had one prior line of therapy, they usually don't say it has to be a certain type of therapy. And so there's usually a mix of different sort of sequences that get enrolled into a given study. Whether or not it really makes a difference, currently there's no evidence that that's the case. And so frankly, I don't exclude each of the main components, platinum, taxane, irinotecan, in some order with a doublet therapy. My impression is that that is what we want to ensure happens, that you get at least access to them at some point. This particular sequence, I do not think makes much of a difference. And this type of study has been done in other cancers, colon cancer, where that exact question was asked and ultimately did not make any difference by sequencing it in different orders and comparing them directly. But that's an excellent question where there's no evidence to date that that's the case, but it's certainly possible, but there's no evidence that that's the case.
Okay, great. Thank you. And this next question is regarding HER2 and the number of patients that are experiencing. You had mentioned it's 15% are expressing HER2 positive. So the question is testing for HER2 standard enough to truly know how common it is?
Yes. When the report came out with the large study called TOGA for trastuzumab for the treatment of gastric cancer, that became an indicated therapy and an indicated test that was considered now standard to test on all newly diagnosed stage 4 gastroesophageal adenocarcinoma patients. And so it is routinely done, and numerous studies have been looked at, and although there's variation of the incidence across studies, as one might expect just from standard statistics, they all hover around that incidence rate of around 15%. We do know that stomach cancer has a little bit of a lower rate of around 10%, and GE junction cancer, esophageal adenocarcinoma, have a bit of a higher rate, 15 to 20%, but as a general average of the whole disease, it's usually referenced as being around 15%.
Great. And as a follow-up to that, are there any statistics for patients who are initially tested positive that lose that status and then are later tested HER2 negative?
Yes. So this is an emerging concept. And so, we've been reporting this, in case reports of seeing this over the years, and breast cancer HER2 positivity is also common in the first place that it was identified and studied. And even there, it's been reported to happen. In breast cancer, it's been reported to happen not commonly. 5 to 10% of the cases can be heterogeneous from through space like that and over time. In this disease, there have been a few reports, and most recently at GI ASCO in San Francisco, ranging from around 15 to even as high as 30% of cases that can evolve to become HER2 negative. And so they're all relatively small studies. But the point is that it's being seen and that it is a real thing. And so my point when I was discussing that is that in second-line specific studies, my advice to companies designing those studies is to ensure that a patient is actually still HER2 positive in order to be enrolled, because we want to ensure that we're treating patients with the actual genetic event in order to get those outcomes. So I would use a range now between 15 and say 25% of cases. And we're conducting a study now looking at this, and some patients maintain their HER2 positive status and some evolve away. And so on our study, which we call Pangea, personalized antibodies for gastroesophageal adenocarcinoma, patients that maintain their HER2 status change chemotherapy in second line but stay on anti-HER2 therapy. Those that evolve away from HER2 positivity to something else, they get a more appropriate antibody that's towards the new thing that's going on in their tumor. And it's too early to say what the rate is in our study, but we've seen both scenarios.
Okay, thank you. The next question is going back to multi-drug cocktails. Is there any indication that using multiple drugs hitting all points of the cell cycle have efficacy?
So that's an interesting question and a good question, and I sort of alluded to that in my last bullet point on my last slide, that combinations of these various things are probably the most likely to prevent resistant pathways from taking over and circumventing any one approach. The problem is that when we add drugs together, that we add toxicities. And so there's a fine balance of, killing cancer, but also limiting collateral damage on normal cells. And so we know, in preclinical settings that if you start addressing all the different parts of the pathway, that yes, you can shut down the cell much more effectively. But when we were referring to 2 drugs versus 3 drugs of just chemotherapy, 3 drugs is typically more toxic than 2, and that's because you're sort of inhibiting it in different fashions and you get more collateral damage. So the answer is yes, we think we can do it, but the challenge is to also make it tolerable, because in the end that is a very, very important thing to be able to do. And
another question is also regarding drug choice, is how does a doctor or a patient choose between similar therapies? For example, there are multiple immunotherapies and drugs for PD-L1. Are they different so that a doctor may choose one based on certain factors, or how is that decision made?
That is a very good question. And for this cancer, because it's not approved yet, it's sort of whatever study a patient can get enrolled on, or whatever sort of compassionate use program that is working for them to get the drug to them. So on the other hand, if and when more than one of these drugs becomes approved in this cancer, that's when that question will become even more relevant, because then there will be options. And so there's similar sort of scenarios in other tumor types, like, for example, lung cancer, where there's more than one drug available. How does one make decisions? So we haven't been confronted with that decision quite yet, because there isn't approval yet, but let's fast forward, say even only 6 to 12 months from now, where hopefully there will be approvals in the later lines of therapy with some of these drugs as monotherapy, and we'll have a choice. So at that point, the answer to the question of whether these drugs are actually different, because they've never been directly compared head-to-head, no one can say definitively. But what we can look at is extrapolations across different studies and look at their outcomes. And in all tumor types, as far as I'm aware, and in this tumor type, the outcomes seem pretty similar. And so in the end, like when I think of these drugs, I do think of them sort of lumped in as a class of drugs that are sort of interchangeable. There are some nuanced differences. For example, some drugs are given every 2 weeks versus some drugs are given every 3 weeks. And so, in the future, maybe when docs are thinking of using a chemotherapy with the drug, one might use it, if they're thinking of using a regimen that is every 2 weeks, they might choose the antibody that's a checkpoint inhibitor immunotherapy that is also given every 2 weeks to keep it all uniform, as opposed to using an every 3 weeks one for that cycle. So that might make a decision. But otherwise, the efficacy or the clinical benefits and even the toxicities are considered similar, if not the same, across these different drugs, as far as I know with the data that we have to date.
Great. Thank you so much. And unfortunately, that's all the time that we have for questions today. But I would like to thank you again, Dr. Catenacci, for your time and this very informative presentation and Q&A session.
My pleasure.
As everyone knows, this webinar was brought to you by Debbie's Dream Foundation Curing Stomach Cancer. Thank you again, Dr. Catenacci, and to all of our sponsors who helped make this webinar possible, including our title sponsor, Boston Biomedical, and our platinum sponsor, Lilly Oncology. Just as a reminder, please check our website and your calendars to join us for an event near you. And I want to thank everyone for joining us today. This will conclude our second in a series of 12 webinars. Our next webinar will be on April 21st. To view recorded webinars and other educational symposia, please visit our lecture library on our website. We'd love to hear your feedback and questions before that time on April 21st, so please send your comments to patient.resource@debbiesdream.org. Thank you for joining us.